All right, colleagues, welcome. Today we're going to dive into what is arguably one of the most challenging injuries we manage in orthopedic trauma, the osteoporotic distal femur fracture.
Okay, let's start with a number that should really get our attention. 13.4%. That's the minimum estimated one-year mortality rate for these fractures. And, many studies actually put it much higher. This really drives home the point that we're not just fixing a bone. This is a life-altering, systemic event for our patients. That reality has to be front and center in every decision we make from the moment they hit the door.
Right, so this is truly a formidable geriatric challenge. And it's not just about the fracture itself. We're dealing with a perfect storm of poor bone quality, multiple medical problems, and very little physiologic reserve in these patients. And the epidemiology tells the story very clearly, doesn't it? The incidence just skyrockets after age 60. And with 83% of these low-energy fractures happening in women, it's no surprise that this lines up perfectly with postmenopausal osteoporosis. This is the classic ground-level fall that results in an absolute catastrophe.
Okay, let's move on to classification and diagnostics. So we all know the AO/OTA classification, right? It's our common language, but it's so much more than just putting a letter and a number on a fracture. The ability to look at the films and say, okay, this is an A1 extra-articular versus, oh boy, this is a C3 with a million pieces. That distinction is absolutely critical. It lets us plan our approach, anticipate the fight we're in for, and start thinking about our implant choice long before we're standing over the patient.
And this is why CT is absolutely non-negotiable. It's not just for mapping out the joint. We're looking for those hidden fracture lines. The coronal shear fracture that you just can't see on a plain film. But more than that, look at this image. This tells the whole story. On the right, you see that paper-thin cortex, the wispy trabecula. That's the junk bone we have to work with. That's where our screws and nails are supposed to get a grip. It's a humbling picture.
All right, now for the main event, the great debate, plate or nail. You know the conversation. It happens every single time one of these fractures shows up on the board. We've got two great tools in our toolkit, but they work based on completely different biomechanical ideas.
For a long time, the locking plate has been the go-to, right? It's our workhorse. We know it, it feels comfortable, and it gives us that sense of direct control over the pieces. But we have to be honest with ourselves. We've all seen the failures. The literature is full of them, and so are our M&M conferences. So we really have to question if it's the right call every time, especially when the bone is terrible.
But when a plate works, it's usually because the surgeon followed the principles. Look at this example. This healed beautifully. Why? Because they respected the biology. They used a long plate to bridge the fracture, and see how they kept the screws sparse in the middle? That creates a flexible fixation. It allows just enough micromotion for that callus to form. This is biology-friendly plating. And here's what happens when you ignore those principles. This is the X-ray none of us wants to see, but we've all had them. Short plate, screws packed in tight right at the fracture, trying to lag comminuted bone together. What does that do? It makes the construct way too stiff. It completely stress shields the fracture. The bone has no reason to heal, and the result is inevitable. It gives up, collapses into varus, and the plate breaks. A total catastrophe.
So that brings us to the other side of the debate, the retrograde nail. The huge advantage here is pure biomechanics. Think about it. We're putting a load-sharing device right down the center of the bone, right down the mechanical axis. It's just built better to handle those axial forces that want to cause that varus collapse we just saw. But, of course, nails have their own set of problems. The biggest one is what we call the Bell-Clapper effect. You've got this wide, hollowed-out metaphysis, and the distal end of the nail can just toggle around inside it. You lose all control of your alignment. And that's where tricks like using a puller screw, like you see here, become absolutely essential. It's a simple little screw that can save the case by narrowing that canal and giving you back control.
This comparison really sums it all up, doesn't it? On the left, the plate gives you that ironclad grip on the distal condyles. You feel like you've really got it locked down. But on the right, the nail is biomechanically superior. It's handling the load the way the bone wants to handle it. So, do you want better distal fixation, or do you want better axial mechanics? That's the core dilemma. So let's just break it down with this table. The plate is load-bearing. The nail is load-sharing. The plate is at higher risk for varus collapse, while the nail gives you superior axial alignment. But on the flip side, the plate gives you better torsional stability and a fantastic grip on that distal bone, which can be a problem for the nail. So you see the trade-offs. It really comes down to this. What is the biggest threat for this specific fracture? Is it varus collapse, or is it loss of distal control?
your answer to that question starts to point you toward the right implant.
All of this, all of these failures and trade-offs, it naturally leads to a pretty challenging question. For the really nasty ones, the highly comminuted fractures in bone that's basically mush, is a single implant ever going to be enough? Or are we just kidding ourselves?
And that question is the perfect lead-in to our next topic, advanced stability with dual fixation. This isn't for every fracture, but it's a critical tool for those absolute worst-case scenarios where you look at the pre-op films and you just know that one implant is not going to cut it.
Think about this number for a second, 19%. In some series, that's the non-union rate for complex patterns treated with a single device. Almost 1 in 5 failing to heal. That's just not acceptable, and it's the strongest argument there is for why we need a better, more stable solution.
And that solution is often dual fixation. The nail plate construct in particular is a really smart strategy. It's the best of both worlds. You get the superior axial load sharing of the nail, and then you add a plate to give you that rotational control and extra grip on the distal fragment. It's the ultimate belt and suspenders fixation for the fractures that need it most.
Okay, so let's bring this all home. How do we take all this information and turn it into a practical decision-making process when you're looking at the films at 2 in the morning and you have to make a call?
Here's a way to think about it. If you have a complex intra-articular fracture, a C-type, your number one job is to put that joint back together perfectly. That usually means an open approach and a locking plate for direct control. Now, if it's an extra-articular pattern, a type A, the nail's biomechanics are your best friend. But, and this is the key, if you see that massive metaphyseal comminution, that blowout pattern in really awful bone, that should be an immediate red flag. That's when your brain needs to switch gears and seriously consider dual fixation.
You know, in the end, it's not about being a nail guy or a plate guy. The real answer is that there isn't one single best implant. It's about having all these tools and knowing when to use them. As the authors of the paper we're reviewing here put it so well, favorable fracture healing can be achieved with plates, nails, and their combinations as long as they are judiciously used. It's all about picking the right tool for the job. So I want to leave you with one last question to think about. We've gotten really good at the carpentry of fixing these broken bones. But is our next big breakthrough going to come from a new plate or a new nail? Or is the real next frontier for us, as surgeons, to finally take ownership of the underlying disease to aggressively manage the osteoporosis that caused this problem in the first place? I think that's where the biggest wins are waiting for our patients. Thank you.